And so I'll start with the session. All the good questions are always a backbone of the evidence-based medicine. And with respect to our topic today, the issue is all the good questions which should come, like, should I give this patient more fluids? Will this patient improve hemodynamically in response to the fluids? Does my fluid bolus likely to augment cardiac output and thereby any improvement in tissue perfusion? Does my patient really needs fluid? How much and how long? So these questions need to be addressed, and for that we will continue with discussion of the topic. In more than 50% of critically ill hypotensive patients, fluid boluses usually fail to augment the perfusion. Hypovolemia is not the only cause for hypotension, whereas under-resuscitation results in inadequate organ perfusion. Accumulating data suggests that over-resuscitation increases the morbidity and mortality of critically ill patients. And we will see that in our next few slides how. So how do we define what is volume responsiveness? Fluid responsive means a response to a fluid challenge by improvement in stroke volume or cardiac output by at least 10%. In fact, specifically by increase in stroke volume, because sometimes the cardiac output still can be increased by increasing heart rate. The static variables like the central venous pressure, pulmonary artery occlusion pressure, right ventricular end-diastolic volume, left ventricular end-diastolic volume, these all have limited predictive value on fluid responsiveness in increasing the cardiac output in a patient with stroke. This may primarily be due to the fact that the ability of the heart to respond to preload does not depend on the absolute value of ventricular volume, but on how that volume is located on the Frank-Starling's curve for that heart. Specifically, the heart must be on the steep portion of the Frank-Starling curve to increase the cardiac output in response to any preload expansion. We see on the left side of the screen, when the stroke volume is plotted against the ventricular preload, we can observe that when the heart is lying on the steep portion of this Frank-Starling curve, for a particular increase in preload, we get a very appreciable increase in the stroke volume. Whereas when it is on the flatter portion of the curve, for the same increase in the preload, we do not get an appreciable increase in the stroke volume. And when the heart lies in the steep portion, it is considered to be fluid responsive. When it lies on the flatter portion of the Frank-Starling curve, it is known as no fluid response to the volume expansion or fluid unresponsive heart. Here we see during the two variables stroke volume versus ventricular preload, see the curve of the normal heart. And now here in this, we see the curve of the failing heart. And in between these two, we see various curves. So what does it signify? That a particular increase on preload, whereas it may have an appreciable increase in the normal heart, but not that expected increase in the failing heart. And this is what we have to understand with regard to fluid responsiveness in response to preload or rather preload dependency of the heart. So these are interchangeable terms. So here we see the preload dependence of the normal heart and preload independence of the failing heart. When we administer fluid in a heart which has into the flatter or the plateau portion of the Frank-Starling curve, and further incremental doses of preload expansion can actually lead to impaired myocardial performance, as seen by this diagram. So the static indices are presometric, Indices are central venous pressure and pulmonary occlusion pressure, whereas the volumetric indices are right ventricular and left ventricular end-diastolic volume and global end-diastolic volume and intrathoracic blood volume. CVP, on the basis of CVP alone, large number of studies fail to discriminate between the fluid responders and non-responders. Only extreme values of CVP are of some clinical significance. Degree of hypovolemia does not correlate with CVP. Factors which increase intramural and transmural pressures can affect the central venous pressure, like pump failure, valvular diseases, dysrhythmias, positive pressure ventilation, peak end expiratory pressure, pneumothorax, asthma, etc. Of course, it needs invasive line too. More than 100 studies have been published to date that have demonstrated no relationship between the CVP and fluid responsiveness in various clinical settings. For long, pulmonary artery occlusion pressure has been considered as the gold standard for determination of LV preload. This also needs invasive pulmonary artery catheter, but the limitation is that it has been found or observed that it is no better than CVP in predicting preload responsiveness. Recent studies have clearly demonstrated that pulmonary artery occlusion pressure is a poor predictor of volume responsiveness. It suffers many of the limitations of the central venous pressure. So why dynamic assessment? More than 50% of ICU patients suffer from iatrogenic harm with respect to fluids, interventions, polypharmacy, rational antibiotics. More evident clinical signs and symptoms are seen after only established flow rate organ dysfunction, which might bring poor clinical outcomes, like fluid overload, gut and organ edema, etc. In the early course of organ dysfunction, clinical signs and symptoms are subclinical and very subtle. This emphasizes the need for constant and dynamic assessment to find optimal goal-directed fluid therapy. And this is why we need dynamic assessment. Fluid resuscitation is based on downstream parameters of microcirculation. When they are based alone on these parameters like serum lactate or central venous oxygen saturation, it may be harmful. Why? Because normalization or decay to baseline of these parameters happen long after actual organ recovery happened. And during that time, if you continue with fluid resuscitation to normalize these parameters, it might result in tissue edema and organ dysfunction. Thus, dynamic assessment of indices of hemodynamics gained momentum because it questions, does this patient really need fluid before actual fluid is given? Is this patient fluid responsive and fall in steep portion of the ventricular contraction? How much fluid needs to be given and how long should it be given? So this is why we need dynamic assessment, because dynamic assessment is able to answer these queries. Dynamic measures of intravascular volume using heart-lung interactions to assess fluid responsiveness is called dynamic method of assessment. We will discuss the heart-lung interactions in detail to understand this concept. It can be in mechanically ventilated patient or it can be in spontaneously breathing patient. Remember that. One aspect mechanically ventilated and then the other spontaneously breathing patient. How do we classify the dynamic indices? First group consists of indices which are based on mechanical ventilation induced variations of stroke volume and stroke volume derived hemodynamic parameters like stroke volume variation, pulse pressure variation, aortic flow variation. These are determined by mechanical ventilation induced cyclic variation in intrathoracic pressure. Second group consists of indices based on mechanical ventilation induced variations of non-stroke volume derived parameters, namely vena cava diameter, ventricular pre-ejection period, etc. Third group consists of indices which are based on preload redistribution maneuvers like passive leg raising. Let us deal one by one. Physiological rationale of dynamic indices of group A, that is heart-lung interactions. Useful concepts in understanding why dynamic indices can predict fluid responsiveness. Effects of mechanical ventilation on left and right ventricular stroke volume. Now let us understand this very clearly. unless until we are able to appreciate and understand heart-lung interactions very well during inspiration, during expiration, in a mechanically ventilated patient, in a spontaneously breathing patient, unless until we appreciate how these heart-lung interactions affect the left side of the heart, how they affect the right side of the heart, we will not be able to appreciate the dynamic indices very well. So it is very, very, very important that all these concepts are ingrained in you very well so that you are able to appreciate and understand and answer the questions based on advanced hemodynamic monitoring or relatively to the dynamic indices. It is very important. That's why at various points it is possible during this course of 3 lectures, I may be repeating these concepts in one way or other whenever we are dealing with a relevant topic, so that your concepts are very clear, and it needs to be very clear. During mechanical inspiration, right ventricular stroke volume decreases. At the same time, the left ventricular stroke volume increases. Now, opposite phenomenon is observed during expiration. Physiologically observed in all patients, but they are much wider in hypovolemic states. Thus, their amplitude, that is the swing in these variables, which are a function of the heart-lung interactions, they are predictive of fluid responsiveness. And because they happen more, the amplitude of that variation happens to be exaggerated during hypovolemic states. We can use these indices to predict the fluid responsiveness. Mechanical insufflation decreases the preload and increases the afterload of the right ventricle. How is it explained? A reduction of RV preload is primarily due to decrease in the venous return pressure gradient that is related in the inspiratory increase in pleural pressure. Whenever there is increase in intrapleural pressure, the venous return to the right side of the heart decreases due to the pressure gradient. Now, increase of RV afterload, which is related to the inspiratory increase in transpulmonary pressure. Why? How we explain small perialveolar vessels. They are compressed, increasing the resistance to the blood flow. So, during inspiration, when there is an increase in intrapleural pressure, their pressure of increased intrathoracic pressure is conducted to the pulmonary artery pressure or the small perialveolar vessels, which are compressed, causing increase in the resistance and leading to an increase in the RV afterload. So the RV preload is reduced due to decreased venous return, and RV afterload is increased, leading to a total reduction in the RV outflow. So RV stroke volume. Now this is minimum, that is the RV stroke volume, then because of this phenomenon is minimum at the end of the inspiratory period, or at the peak of the inspiration, you can say, or at the end of the inspiratory period. It's a cyclical, and then during expiration the reverse will happen. So during mechanical inspiration, the left ventricular stroke volume increases, right ventricular stroke volume decreases, but the left ventricular stroke volume increases, resulting in delta up, that is the inspiratory increase of systolic arterial pressure. Left ventricular stroke volume increases, resulting in increase in systolic arterial pressure. The change or the fluctuation or the exaggerated increase in systolic arterial pressure is called the delta, which we'll discuss in detail again. Inspiratory increase of left ventricular stroke volume, how do we explain that? Increase in transpulmonary pressure. During mechanical inflation, it exerts a squeezing effect on the pulmonary capillary blood, which is emptied into the left atrium, which increases the LV preload, right? It increases the LV preload. because the blood flow more in the LA flows into the LV, so the preload of LV is increased. And a decrease in LV afterload. How? Whenever ITP increases, intrathoracic pressure increases, LV transmural pressure is reduced. So LV afterload is reflected as LV wall stress. LV wall stress is equal to transmural pressure into LV radius. So whenever transmural pressure is reduced, which is multiplied by LV radius, ultimately the LV wall stress or the LV afterload is reduced. In this respect, remember this, in this respect, the mechanical inspiration can be compared to a LV assisting device in situations where LV contractility is reduced. We will further discuss with example. What happens during inspiration? In a mechanically ventilated patient, when there is positive intrapleural pressure, the difference between the aortic pressure and the intrapleural pressure, what we call as transmural transaortic pressure, which is the one which signifies the afterload to LV, that decreases. The transmural transaortic pressure, which signifies the LV afterload, this decreases during inspiration, it decreases, during expiration, it increases. Say for example, during expiration, the aortic pressure is 100 millimeter mercury. Intrapleural pressure during expiration is minus 10 millimeter mercury. So transmural pressure would be 100 minus 10 is equal to 100 plus 10 is equal to 110 millimeter mercury. So 110 millimeter mercury would be the afterload to the LV. Now during inspiration, aortic pressure same 100 millimeter mercury. Intrapleural pressure is plus 10 millimeter mercury because of the increased intrathoracic pressure or positive intrapleural pressure. So transmural aortic pressure would be 100 minus 10 millimeter mercury, which is 90 millimeter mercury. So afterload reduction during inspiration, again remember, during inspiration in a mechanically ventilated patient would be 110 minus 90, that is 20 millimeter mercury. So afterload reduction is 20 millimeter mercury. So this is how we understand that there is an afterload reduction of LV during inspiration and after preload increase of LV during inspiration by squeezing of pulmonary veins. This is how there is an improved stroke volume or increased LV stroke volume during inspiration. So during mechanical expiration, opposite hemodynamic events occur. The right ventricular stroke volume increases because venous return increases during expiration and RV afterload decreases. And the left ventricular stroke volume decreases during expiration, which is responsible for delta down or the expiratory reduction in systolic arterial pressure. So this is the influence of volumic state on heart-lung interaction and how the volumic state will have this influence on interactions. Let's see one by one. If delta down, the systolic pressure variation, right? The pulse pressure variation and the stroke volume variation, they are enhanced. The variation is enhanced when in delta down. When in delta down, these variations are enhanced, they indicate a state of fluid responsiveness. In hypovolemic patients, the SVC, the superior vena cava, collapses on mechanical infusion, determining huge oscillations in the right ventricular stroke volume and left ventricular stroke volume and arterial pressure. After adequate infusion, fluid infusion, the above response is abolished, leading to increase in the cardiac output. So it signifies that whenever there is a delta down, when these variations are enhanced, that indicates a state of fluid responsiveness. You give fluid, the delta down response is abolished. And at the same time, we see that there is an improvement in the cardiac output. So pulse pressure variation derived from analysis of the arterial waveform, stroke volume variation, which is derived from pulse contour analysis. Remember these terms. That's why I marked that in red. The technology is in red. The PPV uses the technology of arterial waveform And the stroke volume variation uses the technology for pulse contour analysis, which we can get from the Pico monitors. And the variation of the amplitude, so this stroke volume variation and the variation of the amplitude of the pulse oximeter plethysmographic waveform, they are demonstrated to be highly predictive of fluid responsiveness. These are all dynamic indices: PPV, SVV, oximeter, plethysmographic waveform changes. They are all dynamic indices, and so we use them to predict the fluid responsiveness. Again, remember the term. The predictiveness of fluid responsiveness means probability. It is just that signifies that, okay, it is probable that infusion of fluid will help the heart improve the cardiac output. It does not mean fluid response means increase in cardiac output of at least 10% or stroke volume of at least 10% by infusion of fluid. That is fluid response. But fluid responsiveness is probability that the heart may respond with increasing the stroke volume on volume expansion. We have already observed preload dependence of ventricle only in the steep portion of the Frank-Starling curve, which is dependent on ventricular contractility. If mechanical ventilation induced preload variation causes wide oscillations in stroke volume and arterial pressure, this suggests that both the ventricles are working on the steep portion of Frank-Starling curve and will presumably increase stroke volume and thus the cardiac output in response to volume expansion. The inspiratory reduction in RV ejection leads to a decrease in LV filling after a phase lag of 2 to 3 heartbeats because of the long blood pulmonary transit time. Thus, the LV preload reduction may induce a decrease in LV stroke volume, which is at its minimum during expiratory period, when conventional mechanical ventilation is used. The cyclic changes in RV and LV stroke volume are greater when the ventricles operate again on the steep portion of the rather than the flat portion of the Frank-Starling curve. The magnitude of the respiratory changes in LV stroke volume is an indicator of biventricular preload dependence. With remarkable consistency, a variation of greater than 12 to 13% has been reported to be highly predictive of volume responsiveness. Multiple times I am repeating the same concept so that it is ingrained. D. Baker and colleagues evaluated the influence of tidal volume on the ability of the PPV to predict fluid responsiveness. For accuracy, reproducibility, and consistency, they suggested that the tidal volume be increased to 8 to 10 ml per kg ideal body weight before and after a fluid challenge. This is for practical application. Which non-invasive technique we can use? The pulse oximeter plethysmographic waveform. This differs from the arterial pressure waveform by measuring volume rather than pressure changes in both the arterial and the venous vessels. As an extension of pulse pressure analysis during mechanical ventilation, the dynamic changes in both the peak and the amplitude of the pulse oximeter plethysmographic waveform, this have been used to predict fluid responsiveness. The pleth variability index is an automated measure of the dynamic change in the perfusion index that occurs during a respiratory cycle. The perfusion index is the infrared pulsatile signal indexed against the non-pulsatile signal and reflects the amplitude of the pulse oximeter waveform. So the pleth variability index correlates closely with the respiratory induced variation in the plethysmographic and arterial pressure waveform and can predict fluid responsiveness non-invasively in mechanically ventilated patients. So this is a flow diagram, a chart, which is plotted against the background of the mechanical ventilatory cycle. See, during this is the inspiratory phase and the expiratory phase. Here we can see in the inspiratory phase the increase in interpulmonary pressure and increase in transpulmonary pressure, increase in pleural pressure. The increase in pleural pressure leads to decrease in the RV preload and decrease in LV afterload. Whereas increase in transpulmonary pressure, it leads to increase in RV afterload and leads to increase in LV preload. We have discussed the physiology behind that. So the result of decrease in RV preload and increase in RV afterload ultimately leads to decrease in RV stroke volume and increase in LV stroke volume at the peak inspiration period, right? So the pulse pressure is maximum at the end of inspiration. After the blood pulmonary transit time, we get a decrease in LV preload and decrease in LV stroke volume. So here the pulse pressure is minimum during the expiratory period. So these are the systems allowing for monitoring of dynamic parameters of fluid responsiveness. So systolic pressure variation, it can actually be eyeballed accurately also, but pulse pressure variation cannot be eyeballed. It requires some of the monitors which we have mentioned here in this table. We can see Litco and Pulsioflex, like that. Philips interview monitors. Stroke volume variation again requires monitors like Litco, Pulsioflex, Vigilio flow track. It can be used, EV1000 volume view, and pleth variability index, which can be monitored by Massimo radical and passive like raising, which we will discuss later. It can be demonstrated with esophageal Doppler or Pico Plus or Vigio flow track. So coming to these group A indices, which are based on mechanical ventilation induced variations of stroke volume and flow stroke volume derived parameters. What is delta down? Is the difference between the apneic and the tele-expiratory systolic arterial pressure. Systolic arterial pressure apnea minus systolic arterial pressure expiration. Delta up is the difference between systolic arterial pressure at inspiration minus the systolic arterial pressure at apnea level. And systolic pressure variation, systolic arterial pressure inspiration minus systolic pressure, arterial pressure expiration. So they require in vivo arterial pressure monitoring and dedicated monitors, all three. Pulse pressure variation is PP max minus PP minimum divided by the average of the two multiplied by 100, required invasive arterial pressure monitoring and dedicated monitor. Stroke volume variation similarly SV max minus SV minimum, this is a little misprint here. Then the mean of the two multiplied by 100 requires PICO or a LITCO. Peak aortic flow velocity, VPK maximum minus VPK minimum divided by the mean multiplied by 100 requires a transesophageal echo. And peak and another we can use is the esophageal Doppler. So let us see. Let's discuss difference between apneic and tele-expiratory systolic arterial pressure is the delta down. And here we can see in this graph, this is the maximum during the inspiration phase, the arterial pressure. So we get, this is the minimum of systolic arterial pressure during expiration. Okay, and the systolic arterial pressure during apnea, this is the expiratory hold. So this is the apnea phase and we get the systolic arterial pressure apnea. So the systolic arterial pressure apnea, this one, minus systolic arterial pressure expiration, this one, that makes the delta down. It needs an arterial waveform and dedicated monitor and has demonstrated the best predictive value for fluid responsiveness. Remember this for your MCQs. And in this same chart, we can see, appreciate the systolic arterial pressure maximum in the inspiration phase minus the systolic arterial pressure of apnea that makes the delta up. So that is the delta up, the difference between SAP inspiration minus SAP apnea. It does not predict the fluid responsiveness. Remember this, delta down is the best predictor of fluid responsiveness. Delta up is not the best predictor of fluid responsiveness. Significant delta up demonstrates that in heart failure states, mechanical insufflation has an enhancing effect on cardiac output. Remember when I had mentioned that it can, in mechanical inflation, can function as a LVAD in heart failure states. This is what I wanted to say. And delta up signifies that if there is a significant delta up demonstrated or observed in any patient on advanced hemodynamic monitoring, we can conclude that mechanical insufflation can have enhancing effect on the cardiac output of this particular failing heart. So we will not guide ourselves with delta up with regard to fluid responsiveness. But in a failing heart, we can decide, okay, yes, this patient will be benefited. So let us continue with the mechanical ventilation till the heart responds or recovers from the failure. Enhancing, why this happens? It happens because of the enhancing LV preload by squeezing the pulmonary capillaries and decreasing the LV workload acting as LVAD. So SPV during mechanical ventilatory cycle is the sum of delta up and delta down. So as we see here, delta up plus delta down, that makes the systolic pressure variation, inspiratory phase minus expiratory phase. Slightly it is less reliable than delta down, and pulse pressure variation for predictive fluid responsiveness. PPV is the arterial pulse pressure variation during mechanical ventilatory cycle. PP max minus PP minimum divided by the average value multiplied by 100 gives you the pulse pressure variation in percentage. This is during inspiration. Then the expiratory phase, you get PP max, and you get, this is the PP max. This much is the PP max, and this is the PP minimum. 12% is the threshold. It has shown as a sensitivity of 90%. It has demonstrated the best predictive value with regard to fluid responsiveness in mechanically ventilated patients. Just like delta down, PPV is also considered as the best hemodynamic monitor. Stroke volume variation, SV max minus SV minimum. This is the SV max, this is the minimum. During expiration, divided by average, multiplied by 100. And needs dedicated monitors like Litco Pico using a pulse contour analysis algorithm. It is less accurate than the others. Peak aortic blood flow velocity variation, VPK max minus minimum divided by average, multiply 100, needs transesophageal echo. Here we see this is the aortic flow. And respiratory variations in delta VP determine the fluid responsiveness. See, we can appreciate these respiratory variations in the aortic flow, blood flow velocity in a probable and non-probable responder, or a probable non-responder. In a responder, we see here, this was the variations, respiratory variations, okay, in pre-infusion, and after infusion, they are almost blunted. So the SVI here was more than 50%, and so we can accept that this was a fluid responder. Here we see the respiratory variations are not much, and so post-infusion there is not much appreciable change. It is less than 15%, so it's a non-responder. This chart shows same PP max and SV max, and I think it's plotted against the airway cycle. So this is the inspiration, the expiration, and the blood pulmonary transit time. We have already discussed this. We can skip these. So why PPV is better predictor than the stroke volume derived variables? Other, inspiratory increase in pleural pressure leads to increase in extramural pressure, right? So this leads to equal increase in systolic pressure and diastolic pressure, right? So the increase in systolic pressure variation can be seen with equal increase in systolic pressure and diastolic pressure, but isolatedly there will be increase in systolic pressure, but since there is an equal increase in diastolic pressure, there won't be change in the pulse pressure variation. Clear? There is an inspiratory increase in pleural pressure, increase in extramural pressure, equal increase in systolic or diastolic pressure. Increase in systolic pressure will lead to increase in systolic pressure variation. But since there is also increase in diastolic pressure, there won't be change in PPV unless until the patient is hypovolemic. In hypovolemic, these will be exaggerated, so that exaggeration will be reflected as fluid responsiveness. That exaggeration we can interpret as fluid responsiveness. There we can get an appreciable change in pulse pressure variation. What are the limitations? In cardiac rhythm is regular, arterial pressure, stroke volume, aortic flow vary beat to beat, and it is impossible to measure the respiratory variation if the cardiac rhythm is irregular. So that is a limitation. The patient is spontaneously breathing, pressure gradients are altered, and ventilation-derived indices become unreliable in predicting fluid responsiveness. Majority of studies use a tidal volume of 8 ml per kg. Differences in tidal volume can affect the predictivity and threshold of the indices. So finally, clinical conditions like RV failure, in spite of an enhanced delta down, stroke volume cannot be increased by fluid infusion because the RV is already failing. So there also it is a limitation. And noradrenaline infusion can enhance the systolic pressure variation and pulse pressure variation independently from volumic state. So that is also a limitation. Thank you very much. Good evening, everybody. So we now move on to the second lecture of the series of functional hemodynamic monitoring and dynamic indices of fluid responsiveness in critically ill patients. And so Group A indices we have discussed already in the first lecture, and now we move on to Group B indices. These indices are also based on the mechanical ventilation induced variations of norms, but the difference between the Group A and Group B is that they are derived from the non-stroke volume derived parameters. These variations, which we are going to measure to predict fluid responsiveness, are from non-stroke volume derived parameters. First in the series of this Group B indices is left ventricle pre-ejection period variation. And let's understand what this is. This is nothing but isovolumetric contraction time of the left ventricle. The interval from ECG R wave to the foot of the invasive arterial pressure wave is actually calculated, and then offline analysis is done, and then it gives us the variation in the isovolumetric contraction time, variation which is induced by mechanical ventilation. So PEP expiration minus PEP inspiration divided by the mean value multiplied by 100. Well, we need a dedicated monitor, ECG and invasive arterial pressure to deduce all this, and we will. So delta PEP, which is the pre-ejection period variation, can also be calculated by using plethysmography, and same formula, but here the ECG R wave to the foot of the plethysmographic wave will be calculated by the dedicated monitor. And in place of invasive arterial pressure, we will use a plethysmographic wave. One is invasive and one is a non-invasive technique. Then we have the measuring the variations in the diameter of the great vessels, which also are very good predictors of the fluid responsiveness. One is the SVC collapsibility index and other is IVC distensibility index. So let us understand the two differences. One is measuring the collapsibility and another is measuring the distensibility. That is by the virtue of the fact that SVC lies within the intrathoracic cavity, and because of its anatomical position, the ventilation or inspiration induced intrapositive, positive intrapleural pressure is conducted to the SVC, which collapses under the influence of inspiration, and the greater the collapse, the greater is the predictive value of the fluid responsiveness. Diameter max minus minimum divided by diameter minimum multiplied by 100, and you need a transesophageal echo for that. We will be discussing all these again one by one. And in the IVC, the IV inferior vena cava dilates under the influence of the positive intrathoracic pressure by the virtue of the decrease in the venous return, and thus the IVC dilates, and then we measure the distensibility of the IVC, which predicts the fluid responsiveness. Here we do not necessarily need a transesophageal echo. We can measure this dynamic index with transthoracic echo or abdominal echo. So coming to left ventricular pre-ejection period variation, as we see, we need an invasive arterial pressure and the ECG curve. And from the start of the QRS complex, the point number 1 to the foot of the invasive arterial trace, the point number 2, we get a pre-ejection period, and this pre-ejection period gives us the isovolumetric contraction time. And the variation in this period due to mechanical ventilation, that gives us the variation, and that variation threshold is 4% and sensitivity is 92%. Right? So that variation which is important to us under the influence of mechanical ventilation, and that predicts the fluid responsiveness. It is an interesting index as it is easy to measure. Only ECG and arterial pressure recording and a dedicated monitor is needed. Plethysmographic delta PEP is even less invasive, and here at least you need an arterial line. There you don't need that. You can use a plethysmographic curve. The key point for great vessel oscillations is that indices derived from oscillations in great diameter vessels, they are considered to be very good predictors because they are very obvious. The changes are very obvious, right? And in fact, the SVC collapsibility index is considered to be the best of all parameters described. Remember, if you get an MCQ to answer which is the best dynamic index from stroke volume derived parameters, your answer would be pulse pressure volume, a variation, pulse pressure variation, right? Or if there is delta down, delta down. So delta down and PPV constitute the best from the stroke volume derived. In case you get all the dynamic indices, covering all the dynamic indices, then the answer is SVC collapsibility index. It shows a bimodal distribution with all the non-phenomena, and so a sharp separation of responders from non-responders is possible. Threshold value is 36%, and it needs a transesophageal echocardiography for measuring this. We see here that in the left half of the frame, you get a patient with a cardiac index of 2.4 liter per minute per meter square. See the SVC is collapsing here. And this was before volume expansion. After volume expansion, we get an improvement in the cardiac index, and it has improved to 2.6 liter per minute per meter square. Let's move to the right side. Remember in the earlier class, in the earlier lecture I had mentioned that if you continue to give fluids beyond a point, it can actually cause harm. And here we see we have got objective evidence to it. In this case, the cardiac index was already 3.2 liter and the SVC was not collapsing. Fluid was administered, and then we see a cardiac index has deteriorated to 2.6 liter per minute per meter square. And so more harm has been done to the patient rather than the good. So IVC distensibility index, it shows a good predictive value. Sensitivity and specificity is more than 90%. Threshold value is 18%. It is a less invasive as transthoracic echo or abdominal ultrasound is used in this case. And we can see here in this picture, this is the IVC plotted against the respiratory cycle. During the expiration, you have the minimum IVC distensibility, whereas during the insufflation, you have the IVC distended and you have the maximum diameter of the IVC. But these values could be affected by the raise in intra-abdominal pressure. Remember that. If the intra-abdominal pressure is raised, these values will not be predicting good. They will not be rendered as a good predictors of fluid responsiveness. So there are limitations to group B similar to group A. These also have been validated in sinus rhythm and controlled ventilation. So the similar limitations apply to this group also. But Having said that, from theoretical point of view, the SVC and collapsibility and DIVC can be useful in patients with arrhythmias or spontaneous inspiratory efforts, since they rely on vessel diameter and not on the cyclic stroke volume variations. So now coming to discuss the group C indices, which are based on preload redistributing maneuvers. See, the important demarcating point here is that group A and group B, they depended on the variations induced by mechanical ventilation, whereas the group C indices are independent of standard mechanical ventilation. So that is the main differentiating point. Remember that. And these have been introduced to overcome the limitations, some of the limitations of group A and group B indices. So there are three described, let us take one by one. Inspiratory right atrial pressure variations. Spontaneous inspiration induced right atrial pressure variations are found to be good predictors of fluid responsiveness. RAP minus RAP inspiration. The negative intrapleural pressure during spontaneously breathing patient is conducted to the right atria, which is responsible for the inspiratory fall in the right atrial pressure. So this you remember as a concept, and you will it will be very clear for you to understand. It can be monitored using a CVP and a PaOP curves. And next is the aortic blood flow variation induced by passive leg raising. Here the difference between the aortic blood flow during the passive leg raising and baseline aortic blood flow is calculated using a esophageal Doppler. So aortic blood flow during passive leg raising, subtracting the aortic blood flow baseline value. That will give you the difference, and that difference will be predictive of fluid responsiveness. Third is the respiratory systolic variation test. Here the lungs are inflated with increasing airway pressures, and then the systolic arterial pressure is measured after every inflation. So inflation induced systolic pressure variation can be determined. What you need? Invasive arterial pressure trace, you need airway pressure monitoring, you need a dedicated recording system for offline analysis. So the delta RAP, if it is 1 millimeter mercury or more, that is a fall in the RAP is 1 or more during inspiration, it is indicative of probability of increase in cardiac output in response to fluid infusion. In studies, it was found that in one of the studies, in 13 out of the 14 patients who had no fall in RAP, when cardiac fluid challenge was given, there was no increase in cardiac output. Whereas 16 out of 19 patients who observed a inspiratory fall in RAP of 1 or more than 1 millimeter mercury, it was seen that cardiac output increased by more than 250 ml per minute with fluid challenge. Sufficient inspiratory effort to lower airway pressure by 2 millimeter mercury is the rider in these cases. So what about the passive leg raising test? Here you see in the picture, just like the picture, passive leg raising test consists of measuring the hemodynamic effects of a leg elevation up to 45 degrees. A simple way to perform the postural maneuver is to transfer the patient from semi-recumbent posture to the passive leg raising position by using the automatic motion of the bed, right? This is a simple way to perform. And see, the passive leg raising is based on the principle that it can induce abrupt increase in venous return, secondary to the auto transfusion of the peripheral blood from the capacitative veins of the lower part of the body. Very clear. Remember this point, the auto transfusion of peripheral blood from the capacitative veins of the lower part of the body. Remember, it is non-invasive, it doesn't need fluids, it doesn't involve heart-lung interactions, it is repeatable and reproducible, it is easily reversible unlike fluid bolus, it can be safely performed in patients with poor cardiac rhythm, it can reliably assess volume responsiveness even if the patient has spontaneous breathing effort or arrhythmias. So how many advantages, and what a simple test to perform. No extra fluid, no heart-lung interaction, no complexity, simple test, so many advantages, and we can get a lot of dynamic indices just by this simple test, which can be done in ICU with the automatic motion of the bed. And you need, of course, a dedicated monitor. We will also discuss the limitations of this test, of course. But in response to PLR, the descending aortic blood flow is measured by esophageal Doppler. The increase in cardiac output can be observed with the help of continuous cardiac output, monitor, dedicated monitor. So the thing that eliminates the subjective element of the measuring the Doppler and all that. The end diastolic volume, the stroke volume, etc. are measured by transthoracic echo. If we are doing want that, we can use transthoracic echo. Pulse pressure variation and stroke volume variation can be measured using a Pico or flow track Vigilio dedicated monitor. So how many indices you can get by a simple test? So now coming, what are the limitations? The intra-abdominal hypertension of more than 16 milliliter mercury impairs the venous return and reduces the ability of the PLR to detect fluid responsiveness. And echocardiographic techniques are operator dependent. It cannot be used as continuous real-time monitoring. So you see how it is done. Get the patient in a semi-recumbent position, take a baseline value, then use the automatic bed adjustment without touching the patient for you may induce pain or etc., which can alter the hemodynamics. So just bring the patient in the 45-degree leg raising position, use a real-time measurement of cardiac output, assess the PLR effects by directly measuring cardiac output, not with BP alone. Then bring the patient back to the normal baseline level. Wait for 1 minute, reassess the cardiac output in semi-recumbent position. This should return to the baseline values, and then you can take a call regarding the volume expansion. So the other is respiratory systolic variation test. Priceman introduced it in order to identify a dynamic index which could be independent from tidal volume. They administered 3 consecutive mechanical inspirations in presometric mode, increasing the airway pressure breath by breath and recorded invasive arterial pressure. Analyzing offline arterial pressure tracing, they identified the lowest systolic pressure after each breath and plotted these arterial pressure values versus the corresponding airway pressure values, obtaining a straight line. The slope of the line, which is called the RSVT slope or the respiratory systolic variation test slope, is the desired dynamic index, and it quantifies the negative effect exerted from the airway pressure to the arterial pressure. The predictive value is extremely good, but measurement is not easy, and thus it is not very suitable for clinical routine. This is a flow chart of spontaneously breathing septic patient where we can see what steps we can do to decide on the fluid response. If the patient's cardiac function is normal, we can just do the IBC distensibility. If it collapses more than 50%, just take a call and give fluid bolus. If the IBC collapsibility is less than 50%, do a PLR. If or doing a PLR, cardiac output is more than 12%, give fluid bolus. Doing a PLR less than 12% cardiac output increase, then you can resort to pressure. Septic patient with a cardiac dysfunction, straight away do a PLR. PLR more than 12%, give fluid, less than 12%, give pressures. So in this one flow diagram, we see this is the mechanical ventilatory cycle. During the inspiration, due to increase in transpulmonary pressure, the increase in pleural pressure, and the changes on RB after load and LV after load and RV preload and LV preload, we have a resultant decrease in RV outflow and increase in LV outflow, leading to stroke volume max during inspiration or at the end of inspiration. And then after pulmonary transit time, there is a decrease in LV preload, decrease in LV outflow, leading to minimum of stroke volume. So these variations are plotted in respect to the ventilatory cycle, and we can here see also that how the right atrial pressure fluctuations lead to the IVC diameter during the inspiration. There is a decrease in the venous return leading to distension of the IVC, and when during expiration again there is a contraction of the IVC. So let us also discuss objectively what are the limitations of the respiratory variation in stroke volume for predicting fluid responsiveness. Respiratory means mechanical variation induced stroke volume changes, which we use for dynamic indices for predicting fluid responsiveness. So what are the limitations of this? Well, when a patient has some breathing efforts under mechanical ventilation, then there is a limitation because the breathing efforts will affect that. And these are more pronounced when the patient is not intubated and patient is spontaneously breathing. When in the presence of cardiac arrhythmias, we cannot interpret correctly. Conditions in which variations in intravascular pressure induced by mechanical ventilation are of small amplitude, like low tidal volumes. Then again, we cannot interpret correctly. And if there is a high frequency ventilation, the ratio of heart rate to respiratory rate is low. That is, if the respiratory rate is elevated, that is the number of cardiac cycles per respiratory cycle may be too low to allow the respiratory stroke volume variation to occur. So high frequency ventilation also we cannot properly predict the fluid response. Then condition like increase in abdominal pressure and then open chest conditions. So these are all some limitations of which can affect the indices which we have already discussed. So what? So next thing is the alternatives to the respiratory variation of hemodynamic cycles. So these are include the recent advances which take away the effect of the ventilation variation and arrhythmias and all those things. So let's see how it is. There are three which have been described: and expiratory occlusion test, mini fluid challenge test, passive leg raising test, which we have already actually discussed. That also comes into the category of alternative to respiratory variation of hemodynamic signal for predicting fluid response. So EEO, it was demonstrated that a 15-second expiratory occlusion test increased the arterial pulse pressure or the pulse control derived cardiac output by more than 5%. The response of cardiac output to a 500 ml saline infusion could be predicted with good sensitivity and specificity. We'll again understand this in the next diagram. Advantage is that it exerts its hemodynamic effects over several cardiac cycles and thus remains valuable in case of cardiac arrhythmias. So this is the main advantage. Other theoretical one is that it can be used in patients with spontaneous breathing activity unless the marked triggering activity interrupts this. Well, the spontaneously breathing septic patient will definitely be in tachypnea and they will not be able to hold in expiration for 15 seconds. So I don't think this is much of practical value. It's more of theoretical value. So what we do here, we start the monitor and take a cardiac index, baseline cardiac index, then apply end expiratory occlusion for 15 seconds. And if the change in cardiac index is more than 5%, then that is indicative of fluid responsiveness. Then you can take a call and then we can consider that the patient is fluid responsive. If the clinical status demands, then you can give fluid. So this is how it is done. This is the airway pressure plotted, and here you see the arterial pressure tracings. And here you have employed 15-second end expiratory occlusion test. And after that, because of the venous return, the preload continues to increase. And when you release that, then you get a upright in the cardiac output, increase in cardiac output, and that becomes the test for fluid responsiveness if it is more than 5%. In the mini fluid challenge, obviously the easiest way to test preload responsiveness is to administer fluid and to observe the resulting effect on cardiac output. Yes, it is obvious. Now the disadvantage of the classical fluid challenge is that it consists of administration of 300 to 500 ml of fluid. Because it is not reversible, such a fluid challenge may contribute to fluid overload, especially when it is repeated several times a day. So mini challenge consists of administering 100 ml of colloid over 1 minute and observe the effects of this mini fluid challenge on stroke volume as measured by the left ventricular outflow tract time integral using transthoracic echo. In a clinical study, an increase in the velocity time integral of more than 10% predicted fluid responsiveness with a sensitivity of 95% and a specificity of 78%. The small volume of fluid is unlikely to induce fluid overload even if repeated several times a day. So it is easy to perform and can be assessed in a non-invasive way. These are all advantages. Nevertheless, a strong limitation is that even in cases of preload dependency, such a small volume infusion will invariably induce only small changes in cardiac output. This test therefore requires a very precise technique for measuring cardiac output. And the disadvantage is that it cannot be used in the presence of cardiac arrhythmias. This table gives us the threshold and predictive value of the dynamic indices, which meant most of them which we have discussed. See, like delta down, the threshold is 5 millimeter mercury, right? And for systolic pressure variation, the threshold is 10 millimeter mercury. For pulse pressure variation, the threshold is 12%. And for the delta V peak, the peak aortic flow velocity, it is again 12%, 13%. Aortic blood flow, change in aortic blood flow, 13%. And delta PEP, that is a pre-ejection period, it is 4%. SVC collapsibility, 36%. IVC distensibility, 18%. Delta RAP, that is the inspiratory fall in right atrial pressure, 1 millimeter mercury. And passive leg raising induced a change in aortic blood flow, 10%. So these are some threshold values. This is a flow chart which shows us how we go about taking a call regarding fluid challenge in acute circulatory failure. If suppose there is an evident fluid loss or it is an early phase of sepsis, the answer is yes, then you can straight away give fluid. If the answer is no, then if the patient is spontaneously breathing, or is there cardiac arrhythmias, or is there low tidal volume employed, or low lung compliance, if yes, any of the answers is to this question is yes, then you can select the passive leg raising test or end expiratory occlusion test or mini fluid challenge test in these situations to determine the fluid responsiveness. If the answer is no to any of these, then you can use pulse pressure, stroke volume, respiratory variation, passive leg raising test, and expiratory occlusion test, and mini fluid challenge. So all these three plus other dynamic indications which are stroke volume which are influenced, like stroke volume variables influenced by mechanical ventilation. So those also can be used. Some general considerations: a common limitation of all indices is that they can predict fluid responsiveness but not indicate the need for fluids. So when dynamic index indicates the state of fluid responsiveness, the decision to give fluid depends on the clinical status in the series. As we discussed, the functional hemodynamic monitoring and dynamic indices of fluid responsiveness in critically ill patients. In this third part of this series, we will try to touch on some practical aspects. We have discussed theoretical aspects extensively in the first two lectures. Now let's discuss or touch something on the practical aspects in a brief way, as there are limitations with our timings. So what is the task of the circulatory system? The whole idea, the concept of cardiorespiratory system functionality is to fulfill the physiological task of ensuring cellular oxygen supply. And hemodynamic monitoring is monitoring whether the circulation is performing its task of oxygen delivery to the tissues or not performing it at the adequate level. Remember that it's all about the oxygen, delivering of oxygen and the energy that is in the form of glucose to the tissues. So it's all about that. And as you have, you see in these three, assess the oxygen supply and the demand ratio. If it's adequate, fine. If it's not adequate, what is the problem? What is the diagnosis of the problem? And then adequately go to the therapy. And then again, check whether the goal is reached or not reached. So in this equation, we see this is the equation giving us the variables affecting the oxygen delivery. You see that the oxygen delivery is a function of the content of arterial oxygen and the cardiac output, which is influenced by variables like hemoglobin, a constant, saturation of oxygen, and cardiac output. So we see what are the variables which we can influence to improve the delivery. So first we see is the hemoglobin, and we can influence it by use of transfusion. In this, then we have the variable of saturation, which we influence by use of ventilation and the fraction of inspired of oxygen, etc. And the third variable, which is still under our control, which we can influence to improve the oxygen delivery, is the volume, cardiac output, which is a function of the volume and the catecholamines. So we try to optimize that. Here we see we have already discussed the delivery. Let's see the this thing, equation of the oxygen consumption. Here we will see that how the central role of mixed central venous oxygen saturation comes into play. So VO2 is cardiac output multiplied by hemoglobin multiplied by 1.3 for the constant of solubility constant, and the saturation of oxygen subtracting the mixed venous saturation. So SaO2 minus SVO2. So that equation will give us a consumption. Delivery we have already discussed. So this is how we see that the mixed venous saturation comes into play for determining how is the consumption, and gives quite an insight of consumption. So when we monitor the mixed venous oxygen and then the other hemodynamic monitors, which we already discussed in the previous two, we get the good balance or an understanding about the oxygen consumption as well as the delivery, whether after adequate optimization of variables like cardiac output, etc., using the advanced modes of hemodynamic bonding, whether we have been able to achieve our objective of the delivery of oxygen commensurate to the consumption. So the purpose of the circulation, of course, is cellular oxygenation. And for an optimal oxygen supply at the cellular level, the macro and the micro circulation as well as the pulmonary gas exchange have to be in optimal balance. Next to cardiac output, hemoglobin and SaO2, it is a mixed venous oxygen saturation which plays a central role in the assessment of oxygen supply and consumption. So no single parameter provides enough information for a full assessment of oxygen supply to the tissues. So these are some key points which we have to keep in mind as we manage the patient. This is a simple flow diagram for flow chart for practical point of view, which we can discuss. Any patient which is receiving oxygen therapy, sedated and intubated and being on ventilation in the ICU, we always use a central venous catheter invasive blood pressure monitoring to help us achieve a cardiovascular stabilization. See for if the CVP is there, so let's see if we have a CVP. If it is less than 8, we can always consider a volume therapy. And after giving certain volume therapy, if suppose the CVP is raised about 8 to 12 millimeter mercury, let us guide ourselves if the mean arterial pressure is appropriate. If it is still less than 65, you think about the vasopressors. If it has achieved the objective of more than 65 MAP, fine. And then we see for the mixed venous oxygen saturation, whether it is less than 70. And if it is so, let's see if the hematocrit is optimized. If not, then we can transfuse to optimize the hematocrit. And then if the objective is achieved, fine. If then less than 70%, in spite of the 30% hematocrit, consider giving ionotropes. After ionotropes, it is optimized, then the goal is achieved. If goal is achieved, just continue with the maintenance therapy. If it's still not achieved, then go back to, again, the basic and try to figure out what is the problem. There we can use the advanced hemodynamic, because still we have only considered a few aspects. We have not gone into that, except that we have added the mixed venous oxygen to see what is the level of the consumption or extraction of oxygen. So here we take the key points. Standard monitoring does not give information regarding the volume status or the adequacy of oxygen delivery and consumption. The CVP is not a valid parameter to measure volume status in isolation, but the trend of CVP can be helpful. In isolation, the CVP has its limitations. If anybody asks you in a question, never say absolutely no. Say that don't give terms like it is outdated or anything. Give that it has its limitations. CVP can be used with its limitation. It cannot be in isolation considered as a sole valid parameter. So the measurement of central venous oxygen saturation gives important information over global oxygenation balance and oxygen extraction. we have discussed this part. Measuring the central venous oxygen can reveal when more advanced monitoring is indicated. So as we have seen here, isn't it? So we monitor the SVO2. If that is inadequate, we take steps. Still inadequate, then we can use judiciously fluid or inotropes by using the advanced monitor. Let's take another simple basic exercise to how we go about practically with regard to fluid challenge. Let's remember, trends and response to infusion are more important than a single value of CVP. I have spoken that, I'm repeating it again. Say for discussion, we take a patient who has a heart rate of 120 per minute, has a mean arterial pressure of 60 millimeter mercury, urine output is about 20 ml per hour, and CVP is about 12. And we decide to give a fluid of say about 500 ml over 20 to 30 minutes. And we give it. After administration of fluid, we get a value of mean arterial pressure of 65, heart rate of 120, and CVP is of 40. What would be the next step? How would you guide? So that's the important. So how we go about it, let's discuss in that. We always have to set some target endpoints with respect to variables, and also the limitations when we are going to stop or limit our therapy which we are utilizing to achieve those variables. So we need to decide to target, we have to decide target goals, and we have to decide the limitations. Just for example, let us decide the target endpoint as heart rate 110 per minute and mean arterial pressure 65. This is for discussion part, this is for example. You can on your own decide a target of, say, with respect to urine output also, and oxygenation status also. Here we decide, say, limitation of CVP of more than 60. So let's go about it. Now, consider the first scenario here. Mean arterial pressure 65, heart rate 120 per minute, CVP is 14. So our target endpoints have not been achieved. Here we set the target endpoint of heart rate less than 110. So this has not been achieved, right? And the limitation has not been crossed. Limitation of CVP of more than 16, which we said, this has not been crossed. So we can continue to give them. Here mean arterial pressure 70, heart rate 110, CVP is 14. Now see, we see here the target endpoints have been achieved, although the limitation has not been crossed. But since our target endpoints of variables which we had decided before instituting the fluid therapy, it has been achieved, what we should stop here. So we will stop the fluid. Consider the third scenario. MAP is of 65, heart rate 120, CVP of 80. Here again, if we see, the target endpoints have not been achieved. But on the contrary, the CVP limitation of 16 has been crossed. So the limitation has been crossed, targets have not been achieved. So again, we will take a decision to stop the fluid. And then we will, what we come to the conclusion, standard parameters do not give enough information in unstable. What other parameters do I need? Always the extended hemodynamic monitoring is to aid the therapy in order to optimize the oxygen supply and oxygen consumption. This we have to always keep it in mind, so that we keep on deciding our target endpoints and limitations accordingly. So cardiac output monitoring plays an essential role in the critical care. Should be considered whenever a patient remains hypotensive despite adequate fluid resuscitation. And when there is ongoing evidence of global tissue hypoperfusion, you need a cardiac output monitoring. Shock with mixed pathology. What is the mixed pathophysiology? What we are talking? Let's say, for example, to explain, we have a patient who has an existing coronary artery disease. Now he develops a community-acquired pneumonia, goes into a picture of sepsis, kind of like a picture, and comes with in a shock. Now, you do not know for sure whether the shock is because of the coronary artery problem or is it because of the pneumonia problem. So to improve our understanding and get more information, that's why we need advanced hemodynamic monitoring, and there is a role of cardiac output monitoring in that. We will not just think about giving the fluid or optimizing the therapy based on the blood pressure alone or the heart rate alone. We need more information. In cases of post-surgery with major fluid shifts, say like cardiac surgery, vascular surgery, major vascular surgeries, transplant surgeries, all here in these are the situations where you need cardiac output monitor. Always assess the adequacy rather than just numbers in isolation. End organ perfusion assessment is most vital. And clinically, brain by assessing the confusion or the altered consciousness status, kidney by assessing the urine output, skin by the capillary refill time, which should be less than 3 seconds, and the biochemical values of lactate, which gives us the idea of the homeostasis at the tissues level. These are all windows and in our clinical picture, which we can give us an assessment of the perfusion status of the individual. But always remember, by the time the brain the window of brain shows unmasks the altered consciousness, or the urine output falls, or the refill time gets prolonged, or the lactate goes up, till that time there is very much possibility that some vital damage to the vital organs may have set in. So these are windows. Yes, they will give you obvious signs when a person or a patient lands up with you in the emergency setting or in the ICU setting, ideally in the emergency room first. So they are, but if you have a patient already admitted and if you find him deteriorating, it is always preferable to use the advanced hemodynamic monitoring before these kind of deteriorations in the vital organs start giving you the picture or scenario. Before these windows are revealed, it is always better to preempt the diagnosis, use advanced hemodynamic monitoring, and optimize the hemodynamics and homeostasis before these windows start deteriorating. Here we come and discuss some practical value of this tidal volume challenge. See, remember in our previous lectures, we discussed that one of the limitations for the advanced hemodynamic parameters like pulse pressure volume and other stroke volume derived parameters under mechanical ventilation, when we monitor them, when we calculate them and take a call regarding the fluid responsiveness of the patient. There, one of the limitations was that the patient should have at least 8 ml per kg tidal volume. In those patients only, the data will reveals that we can predict the fluid responsiveness. Now, what about a practical problem that we may have? A patient who is requiring a low tidal volume ventilation. In those patients, how do we go ahead and monitor the fluid responsiveness state if we want to do using the stroke volume parameters or advanced this thing? Of course, you have a passive leg raising, but even that is a issue in some of the situations where we cannot, in a polytrauma patient, you maybe not be able to do a passive leg raising. So, always one size doesn't fit all. So you have to have techniques development where which can overcome some of the limitations of the already existing. So, well, I would like to discuss this tidal volume challenge test here. It was published, this work was published by our renowned chairperson of this session, Dr. Diwatiya sir, and along with his colleagues, they published it in Critical Care Medicine in 2017, and let us see what they had to say. They hypothesized that transiently increasing the tidal volume from 6 to 8 ml per kg ideal body weight and measuring the pulse pressure variation may help unmask the fluid responders. So we already discussed that in the higher tidal volume patients, no problem. But suppose the patient is on a low tidal volume ventilation, say for example 6 ml. So they are saying you increase that transiently to 8 ml or 10 ml per kg ideal body weight, so that we can have a pulse pressure variation measurement and we can see the difference in the low tidal volume state and the high tidal volume state. And that they say that it unmasks the fluid responders. This tidal volume challenge by increasing 2 ml per kg IBW in the patients on low tidal volume ventilation can be used to predict the fluid responsiveness. They observed that a delta PPV, that is a pulse pressure variation change of 3.5%, predicted the responders with a sensitivity of 94% and specificity of 100%. So what did it mean? 3.5 means that, say the PPV was a certain value in the 6 ml per kg IBW, and when we increase transiently to 8 ml per kg, and after 1 minute we measured the PPV, then the change has to be 3.5% in order to predict the patient as a fluid responder. And the sensitivity of this 3.5% delta PPV change was 94% with a specificity of 100%. So in this way, we can overcome that limitation. So these are some advanced which we use: echocardiography, pulmonary artery catheter, PICO technology. So PICO technology setup, this monitoring uses the basic hemodynamic monitoring, but delivers advanced hemodynamic monitoring information. We see what we require here is a central venous catheter here, right? And with a port for injected temperature sensor housing. Then we use a cold saline, say as a injected, which goes into the right side, then the pulmonary circulation, then the left side of heart, then the arterial or the systemic circulation. And we have here a arterial catheter, PulsioCath, arterial thermodilution catheter, and usually in the femoral artery. If for some reason we cannot cannulate this, we can use auxiliary or a brachial one. Then with the cables, the information sensed after the transpulmonary thermodilution is delivered to the monitor, and which gives us the after proprietary formula which will give us the values. This technology is a combination of the transpulmonary thermodilution and the pulse contour analysis in the PICO. So we get a transpulmonary circulation, we already discussed, from central venous bolus injection, goes to the right side of the heart, then to the left side of the heart, and through the pulmonary circulation into the left side of the heart, and from here to the PulsioCath. So from PulsioCath, here we can get the arterial waveform analysis, which will use the pulse contour analysis, and then we have a transpulmonary thermodilution. So it's a combination of pulmonary thermodilution and pulse contour analysis in the PICO technology. After the central venous injection, the cold bolus sequentially passes through the various intrathoracic compartments: right heart, lungs, then pulmonary blood volume, then the LA, the LV, and then the concentration changes over time. The temperature change over time is registered by a sensor at the tip of the arterial catheter. So the therapy guidance is that advanced hemodynamic monitoring allows the establishment of an adequate cardiac output through optimization of volume status while avoiding lung edema. This is the basic principle of the triad of advanced hemodynamics. So let's discuss this flow track Vigilio a little bit in detail. This monitor, flow track Vigilio, this analyzes the waveform about 1000 times per second over 20 seconds. 100 multiplied by 20, what do you get? About 2000 data points for analysis. This is then incorporated into a proprietary formula to calculate the cardiac output. And then we get the cardiac output and all the derived variables. So like we can get the cardiac output, we can get the stroke volume, we can get the stroke volume variation, we can get the stroke volume index, all these variables we can get. So what does it incorporate? Dynamic, this is known as dynamic tone technology. For which monitor? The flow track Vigilio, right? Remember that. This is an important point. You have to mention this while answering this short note or any question which involves flow track Vigilio. See, it analyzes the area under the systolic portion of the curve. Whenever you get a question on this PICO technology, you always mention this dynamic tone technology. And there are about 2000 points, dynamic tone technology, multiple measurements along waveform. 2000 data points are incorporated and that are analyzed, and then it gives the picture of the stroke volume and the stroke volume derived variables. So these 2000 points are incorporated in the what is known as the dynamic tone technology. So remember here, anyway, I'll discuss that in next time. Here in this Vigilio monitor, we see this is the what is known as Edwards precept catheter. Okay, Edwards are preparing that and giving they are marketing it. So this is known as precept catheter, which monitors the central venous oxygen saturation. And then we have this flow track sensor to give us the cardiac output variables. So in this monitor, it supports both the flow track sensor for continuous cardiac output and the precept central venous catheter for continuous central venous oximetry. So we are able to get the SCVO2, it will give us the idea of the oxygen extraction. And by the help of the cardiac output variables, we can have a fair idea about the oxygen delivery through the hemodynamics. So it measures the variations of the arterial pressure, which is proportional to stroke volume, right? Whatever variations happen in arterial pressure, they are subject to the changes or variations of the stroke volume. So that it measures this dynamic tone technology and displays the key on a continuous basis every 20 seconds. This is less invasive, requiring only an existing arterial catheter. Essentially, no calibration is necessary. Remember this. In the PICO technology of transpulmonary catheter, transpulmonary dilution, what happens? You inject a indicator fluid, it passes through the circulation, reaches the arterial site, and then the difference of temperature is measured, and thus you need some calibration of the system. In this arterial waveform pulse contour analysis, we are talking about the pulse contour, the arterial waveform pulse contour analysis, and pulse contour analysis derived variables as a cardiac output and cardiac output variables. Here, there is no transpulmonary circulation involved. It is the 2000 points which are analyzed on the arterial pressure tracing, mainly the systolic portion of the that curve. So here there is no calibration which is necessary. The user simply enters the patient age, gender, height, and weight to initiate the monitoring. And the measured parameters we can see, we can get a continuous cardiac output, cardiac index, stroke volume index, stroke volume variation. And the derived parameters like SVR, IE, DO2, oxygen delivery, and oxygen delivery index. The stroke volume values are used to guide the pre-load responsiveness, which is usually more than 12%, which we have already discussed earlier. These are some normal ranges, these are the parameters, cardiac output, normal range 4 to 8 liter per minute, and like that. Always go through the text and remember these normal values. The reason that if suppose you are getting any exam, and in the exam, you usually may get some case-based scenarios or some values, and then to interpret the data, you need to know what are the normal values so that you are able to differentiate the normal and the abnormal value and guide yourself to proper answering the questions. So please do that. So your whole optimization of cardiac output is dependent on mainly these three types of variables. One is the preload and contractility, which is a function of the Frank-Starling mechanism. Then the afterload and the chronotropy. I think these are, you know. This is an interesting picture, the thermodilution curve, so it's shape of that, and the shape is correlated with cardiac output. So with a broadly, when you observe the thermodilution curve itself, then you can always correlate with your cardiac output, whether your curve is correlating with the cardiac output which is shown on the monitor. The area under the thermodilution curve is inversely proportional to the cardiac output. Sometimes if you do not know this concept, you may get a doubt in your mind. Oh, this curve is so small. How do I get that cardiac output 19 liters per minute? Here you say that, oh, this cardiac curve is so big, I should have got a very good cardiac output. The monitor shows 1.9 liters per minute. And this, of course, is a normal cardiac output curve with a normal cardiac output. So remember this concept. This is why I shared this. So in this transpulmonary versus pulmonary artery, this is the transpulmonary thermodilution, which is used by the PICO technology. This is the pulmonary artery thermodilution. We all know how this PAC works. So in both procedures, only part of the injected indicator passes the thermistor. Nonetheless, the determination of cardiac output is correct, and it is not amount of the detected indicator, but the difference in temperature over time that is relevant. Right? But always remember, if you are going for an absolute value of cardiac output, it is always a PA catheter which will give you the more accurate, or it's the accuracy of PA catheter in determining the one isolated value of cardiac output. You have to depend on PA catheter. If you go for this technique, the one isolated value may not be very accurate. So this technology can be used, pulse contour analysis technology can be used for the trend. The trend can give, so for an analysis of trend will give you a fair idea, but for absolute values always go for a PA catheter. There are many other aspects like the tone and the compliance and the arterial elastance and so many other factors which influence. So the pulse contour analysis may not give you the exact accuracy of cardiac output in an isolated way. So that's why there the trend is important. And in the PAC you can get absolute value. PICO and flow track technology is less invasive method for monitoring the volume status and cardiovascular function. These are some key points we have for revision. Transpulmonary thermodilution allows calculation of various volumetric parameters. The cardiac output is calculated from shape of the thermodilution curve, and the volumetric parameters of cardiac reload can be calculated through advanced analysis of the thermodilution curve. For the thermodilution measurement, only a fraction of the total injected indicator needs to pass the detection site, as it is only the change in temperature over the time that is relevant. So in this slide, we see the calibration of the pulse contour analysis. It is calibrated through the transpulmonary thermodilution and is a beat-to-beat real-time analysis of the arterial pressure curve. The SV obtained with the thermodilution is placed in relation to the AUC under the systolic part of the arterial pulse. This one is the systolic part. Alright, so that the stroke volume obtained with the thermodilution is placed in relation to this portion. Using this calibration, the cardiac output can be determined continuously from the arterial pressure curve. So cardiac output through transpulmonary dilution divided by the heart rate will give you the stroke volume through the thermodilution. So this is how the system calculates. Dynamic parameters of volume responsiveness. This slide we have seen in our earlier lecture also. We can see how we get the stroke volume max. This is the SV minimum. Then we calculate the variation, SV max minus SV minimum divided by the stroke volume mean. So this is the inspiratory increase in stroke volume. This is the expiratory decrease in stroke volume. And this variation is the variation in stroke volume over the ventilatory cycle over the previous 30-second period. Remember that. Similarly, here we can see the pulse pressure variation, which is measured over the previous 30-second period in the same way. So this slide shows us the calculation of extravascular lung water, which is the difference between the intrathoracic thermal volume, this one, minus the intrathoracic blood volume. It represents the amount of water in the lungs outside the blood vessels. Right? The intrathoracic thermal volume, intrathoracic blood volume. So what is remaining? That is the extravascular lung water. It is the difference between the two waters. It represents the amount of water in the lungs which is outside the blood vessels. So we see here is extravascular lung water index, the normal range, On the right side of the frame, we see the X-ray of the patient who has a extravascular lung water index in the normal range. On the left side of the frame, we see obvious pulmonary edema, and the patient's extravascular lung water index was outside the normal range or higher than the normal range. So knowledge of the limitations is essential. We discuss in this slide the limitations of pulse contour analysis. The stroke volume variation, pulse pressure variation can only be used with fully controlled mechanical ventilation. That is, the minimum tidal volume has to be more than 8 ml per kg. And absence of cardiac arrhythmia, otherwise it may give false high reading. All parameters of pulse contour analysis, they are not valid when an intra-aortic fluid counterpulsation is in use. What happens when we are using that analysis of pulse contour in special situations? We are using along with RRT, normally no interference with the PICO parameters. Broad positioning, all parameters are measured correctly. If we use peripheral venous injection, this is not recommended, because then the measurements possibly can be influenced. What are the contraindications of pulse contour technology? Because of low invasiveness, there are no absolute contraindications. Only the usual precautions which are required are regarding puncturing the larger blood vessels, like coagulation disorders or vascular processes. If there is a vascular process, you can use a different puncture site. So what's the take-home message? No device is perfect. Data showing that any of these monitoring devices improve patient outcome is very low. So major use of these devices is to optimize the resuscitation by determining the fluid responsiveness, integrate and interpret the patient's clinical, hemodynamic, lab and radiographic data. The choice of device depends on the additional information which is provided by the device. Thank you very much.